Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Calafella, also a Melbourne-based GP. We've got a great episode to start 2025 off, don't we, Dr. Anne? We are covering lots of things. We've got Human Metapneumovirus, which has been on lots of people's social media radar and making some rounds along the news, so we'll talk a little bit about that. There's a little bit of a Measles update where we'll talk about some things that might be important for Australians to think about when they're thinking about measles. And we've also got some news around Depo-Provera and its risk for a very rare side effect. Very excited for today's episode.
Yeah, and we'll cover just a little bit of housekeeping. First of all, Happy New Year to all of our listeners. We all had a great holiday period and are looking forward to 2025. But as you'll recall, perhaps from our last episode last year, we have decided to move to fortnightly podcasts to try and maintain quality. And we're going to do our best to keep them slightly more bite-sized. So we're aiming for around 20 minutes each time. So wish us luck and we will see how we go. And I'll remind everyone that, as always, a podcast can't replace individual advice from your own healthcare provider. And with the admin out of the way, Dr. Moz.
You'll be able to see how well we've kept to the task of 20 minutes because we don't know how long this podcast is going to be yet. But yeah, we're hoping for 20. Very good. Excellent. And let's dive in, Dr. Anne. Human Metapneumovirus. There's a lot of chat online. There's video footage of hospitals in China overflowing. There's chat on every social media group, COVID 2.0, we're going to get locked down again. There's going to be forced vaccinations and mandatory things of all kinds of descriptions. What is human metapneumovirus and what is this new virus that we're all hearing about?
I mean, it's not new at all, is it? It's been around for more than 50 years. I think not recognised till something like 2001, but then when they went back and looked at stored blood samples, it's been around forever. Yeah. So we hate to reduce the excitement, but it's been around forever. It's not more common at this time of year in China than it has been any other year. And we're not worried about it. The World Health Organization isn't worried about it. Because it's been around for so long, it means that most people have some degree of protection from it. So it's entirely unlike the COVID situation, which was a novel virus. Every single person in the world was susceptible, which was why there was the possibility, and then it worked out that there was a pandemic. There is little to no chance. It's super unlikely that the metapneumovirus will result in a pandemic.
Yeah, and I think, we've talked a little bit about the fact that, our behaviour as clinicians has changed since COVID in terms of performing respiratory swabs on lots of people. And one of the consequences of that is, rather than be told, you've got a common cold, off you go, you're actually being told you have rhinovirus, adenovirus, whichever version of virus. And there's been plenty of human metapneumovirus diagnoses in the last 4 or 5 years, thrown around. So I'm not quite sure if this is just a case of someone's got some really good footage and it's taken off and the world loves disaster and disaster sells stories and is really good clickbait. But
I think it's a bit of deja vu.
I'm struggling to work out what's so interesting.
Yeah, because it's northern provinces of China and we're seeing hospitals apparently overwhelmed, but China deny that they're overwhelmed, and the World Health Organization say the data that they've looked at suggests there's not any unusual problem. So the other thing to say is that human metapneumovirus, that for the main part causes mild respiratory illness, and we think that concern is overstated.
Yeah,
watch this space. We'll keep
nobody at this point in time is talking about a new version of the human metapneumovirus. They're just talking about human metapneumovirus. And so for everyone that's really worried about, a repeat of the precautions that were taken around COVID time, all of those precautions were around the fact that it was a novel virus and we wanted to restrict the number of people that were infected or exposed to it. Almost everyone's been exposed to this. So I don't know that there'd be any scientifically sound advantage to a 5-kilometre radius restriction in the context of human metapneumovirus.
Oh, I think not. Okay, so that's probably all we have to say about human metapneumovirus.
Storm in a teacup. Yeah.
Indeed. So we'll have a quick chat about measles next. We'll keep the chat quick because our very first podcast back in August, I think last year, we spent a good bit of time talking about measles, but it's back in the news because there have been 4 cases in recent weeks in Victoria.
Yeah. And much like last year's podcast, again, the primary source is return travellers, isn't it, Dr. Anne? That seems to be a really good source of measles infection
so return
in Australia.
travellers, from Southeast Asia, so sort of Vietnam, Thailand, and return travellers usually of a certain age, from the middle 40s through to the late 50s, because we are that generation who are most likely to be under-vaccinated. So why is it important? Why do we care? There's been 17 cases.
And just to clarify for people who didn't listen to the last podcast, that's not a comment on entitlement or any of those kinds of things. It's primarily just a timing glitch as to when the measles vaccination became available, and also the fact that that age bracket seems to be quite good at travelling because they're at a stage of their life where they can. So they're slightly under-vaccinated, and they're in a stage where they can be quite mobile and return home with some measles, which is less than ideal. But why do we care, Dr. Anne?
We care because measles is super, super infectious. So the R0 figure for measles is 15 or 16, compared to 2 or 3 for the common cold or COVID itself. So the R0 figure, for those who've forgotten since the COVID times, that would be the number of people on average you would predict to be infected by a person who had the disease. So if you have a susceptible population, somebody has measles, we would expect 15 or 16 people to be infected by the first case.
Yeah, that's right. And for comparison, because I think it's the thing that everyone compares to. So we've said, if I happen to be unfortunate enough and have measles, I'm probably going to infect about 15 or 16 people. What about if I had COVID, Dr. Anne? How many people would I be expecting to infect?
2 or 3. And I suppose the important thing is to point out that you would be theoretically infecting 15 or 16 people if they were all susceptible. And the bit that we need to get to quickly is that the susceptible population in Australia are our infants under 12 months. That although we're seeing that the mid-40s to late 50s are susceptible, they'll be a bit ill, but mostly will recover. They'll be a bit sad and sorry for themselves, but unlikely to die. That is not the case for our small children who are unable to be vaccinated.
Yeah. And again, I think this stat made its way into our last podcast. It's actually quite a nasty bug. I think you've popped down into the show notes here. 20% of people who are infected will become hospitalized, which is a pretty significant number. Like, 5 people with measles, one of them was probably in hospital.
Yep. And that's at any ages, higher in the small children. So it can cause pneumonia, it can cause brain swelling, brain inflammation, encephalitis, death. We don't want our small children to get this. So we need the Gen X's to get themselves protected. That's kind of the take-home message. The other thing to say is that if you are exposed to measles, if you've come into contact with one of these cases, it is worthwhile getting a booster vaccine within 72 hours of your exposure. That's assuming you're in that age group that's under-vaccinated. So you can get a free MMR vaccine if you're in that age group, anybody born after 1966, including 1966, and get a free vaccine. And getting vaccinated after your exposure works the vast majority of the time.
Mm-hmm. And I think that's an excellent segue to, I guess, who's at higher risk. There's a special age group here that I don't think we've said anything about, but it leads to a whole, rabbit warren of problems for pregnant women as well, including, fetal abnormalities and stillbirth.
Yeah.
So we definitely don't want that. So if you are under-vaccinated and you have some sort of additional problem like you're pregnant or you're immune compromised, is there any additional advice for those people, Dr. Anne?
There is indeed. For our infants under 12 months, for our pregnant and for immune compromised, they can actually get human normal immunoglobulins. That's somebody else's antibodies. Can be given to you up to 6 days after your exposure and greatly reduce the chance that you'll get symptomatic infection. So I guess we have to be listening to these alerts from the Vic Health Department and sign up for the alerts. If you put a link in the show notes for that. If you are under-vaccinated and have been exposed, you need to get in touch with your doctor. Either you're eligible potentially for the MMR vaccine, or if you are increased risk over and above that, you can get the immunoglobulin. That all has to be organised. The doctor doesn't have the immunoglobulin in stock.
No, we don't have immunoglobulin floating around.
It's very precious, pooled stuff, and there's a process to obtain it. It doesn't happen instantly. So
to summarize, nasty bug, really infectious. 1 in 5 of everybody will end up hospitalized, but there are some groups that are much better at being hospitalized. You should definitely get immunized if you are if you suspect that you're under-immunized. And if you're not sure, go to speak to your doctor, and I'm sure they'll work out whether you're in a high-risk group or not. And then there are some very fancy drugs if we are in a high-risk group and we are exposed.
And we have much more detail in podcast one if anybody wants to know more and more and more about measles. So we'll leave it
Maybe
there.
We'll put a link to the episode on the show notes as well.
We can do that. So the next thing that's been in the news, medical news in recent weeks, has been about a French study that reported a 5-fold increase in meningioma in users of the contraceptive injection Depo-Provera. So we should have a little bit of a chat about that. Sounds very scary.
I guess let's talk about those two terms before we dive into the data. So meningioma is usually a benign brain tumor, but sometimes it does need an operation and it can cause problems. And the Depo-Provera shot is a version of progesterone contraception. So other versions of progesterone contraception would include things like, the Implanon, the Mirena, the mini pill, and even the usual pill has some progesterone in it. And so not an uncommon medication to be used in the contraceptive world. So tell us about the study, Dr. Anne.
Sure. The headline of the study was that in people who had used the contraceptive injection for at least a year, there was 5 times the risk of requiring surgery for a meningioma, which as the headline sounds super scary. But we need to look a little bit more both at this study and also at how actually common meningioma is, because the answer is it's not very common. So the actual numbers were that meningioma is quite rare overall, that the case rate is 1 in 10,000 for women not in Depo-Provera, and for women who were in Depo-Provera, the rate was 5 in 10,000 or 1 in 2,000. So 1 in 2,000 makes it officially a rare event for medications as official agreed listings for when something is uncommon, common, rare, etc. And at 1 in 2,000, that would be regarded as a rare side effect. And why? Because 1 in 2,000 is not a common scenario. So that's the first thing to say, is that the absolute risk is actually quite low. The second thing to say is that this was what we call a case control study, which is not amazing quality evidence, is it, Dr. Moz?
No. So, case control studies aren't considered the gold standard. There is a bit of a hierarchy that we sort of think about when we're looking at studies and trying to decide how valuable the evidence is likely to be. So case control studies are still helpful, and you can still learn a lot from case control studies, but often we want to replicate that data in higher quality studies with higher numbers of patients. And so there's still stuff to be learnt around the relationship between Depo-Provera and the meningiomas, or indeed any other high-quality case control study, but we wouldn't classify it as gold standard, no.
No, we would not. And I guess for the audience, in case you're a little bit interested, what is a case control study? In this particular study, what they had 18,000 women who were admitted to French hospitals for surgical treatment of a meningioma, and they matched them, each single one of them, with a woman born in the same year who lived in the same postcode district who didn't have a meningioma, and then we looked at their use of progesterones. It's definitely an interesting statistic, but the usual result of a case control study is that this is interesting, is indicating a trend, and that more work is needed, more to get higher quality evidence.
Yeah, absolutely.
So it's been in the... Sorry.
No, please.
It's been in the news primarily because there were talks of class actions both here and overseas. So all very interesting. I guess our take on this situation would be that women should not immediately stop the contraceptive injection. They should speak to their healthcare practitioner at their next visit about it. And in fact, for us, not many of our patients are on Depo-Provera because of concern over bone health, which I think we covered in a previous podcast.
So, yeah, I think that sounds like excellent advice, Dr. Anne. And I think the other thing that we sort of talked a little bit about is, we won't have an opinion on this particular case, but this really just does bring up a topic that we've sort of touched on a few times over the last, 19 or 20 episodes, which is that material risk conversation, isn't it, Dr. Ann? So we've used that word a couple of times, or we've explained it a couple of times, but maybe we'll explain it again, because I think that's exactly what we're talking about here.
Yeah, well,
So
we'll
what is
explain it
material
again,
risk?
but I think important to say that at the moment we probably don't have enough information to understand whether this does constitute a material risk, and because there is litigation pending, class action cases, we probably need to be on record as saying we're not sure. But I think now that it's been talked about, it probably will be talked about in consultation. So anyway, a material risk, it's the objective prudent patient test, I think, is the legal definition. So that if a reasonable person in the patient's position would attach significance to the information, if they were made aware of it, then that information should be given to the patient. Yeah?
Yeah, absolutely. And I think, the example that I always remember from med school is probably a terrible example, but, they talk about if you're doing some rare operation and there's a 1 in a billion chance of blindness, that may not be as important for you or I, but for a person who only has one working eye, then that becomes slightly more important, and you should probably have spoken specifically to that patient about that risk.
Well, that's right. So there's the objective prudent patient test, but there's also the subjective arm to the ruling. And the subjective arm is that if you know or should reasonably have known that the particular patient placed unusual reliance or interest in the information, then you also have to tell that patient, even if the average patient would not have been interested or concerned.
Yeah. And so I guess that's what the lawyers are trying to work out. Is this a material risk or not? And I think from our end, like you've said, we don't have a specific opinion. We think that there's not enough data here to decide.
If it was a material risk, I guess, is what the lawyers are trying to work out, and also at what point it was reasonable to expect that the manufacturers were aware of it. So the manufacturer has updated the data sheet as of February last year. But what it says is that if a patient on Depo-Provera is diagnosed with a meningioma, you should stop the Depo-Provera. And also says if the patient has a history of meningioma, then you probably should think very carefully about whether it's wise to start them on it. That's as far as they have gone. So I guess it's an interesting space. As we tend to use Depo-Provera, I think the words you used were as thinking music in our long-acting reversibles podcast. It's useful to give someone 3 months of working out what they want to do, sometimes even 6 months, because long-term use can adversely affect your bones. We're not fans of it. It's not actually terribly commonly used in Australia overall. I think 2% of women who contraceptives an issue for will use Depo-Provera, and then Victoria's even less than that, so 1.5%. And I think in our population it would be less than that, to be honest.
Yeah, less than that. I think of all of the patients, I think there's one patient who's on long-term Depo. It's for a variety of complicated reasons.
So definitely talk to your doctor about it, but I think not lose your mind over the risk. It is a rare risk, and we don't really know positive as yet. But ever watch this space.
Excellent. One final thing, maybe because we're doing okay time-wise, Dr. Ann, and we haven't hit our 20-minute mark just yet. We're seeing a lot of chatter online about snakes. How worried should we be? What should we do?
Well, we talked about snakes in our very last podcast of 2024, and our advice hasn't changed. So basically, try and stay away from snakes. They will actually try to stay away from you. So be aware of them. Try not to step on them. Stay away from long grasses, and be a sensible human being. But if you are bitten by a snake, then move only as far as you need to get away from the snake, and immobilize the bit that's been bitten and call for an ambulance.
Indeed, and we covered the first aid in a bit more detail on our last episode, so we won't go over that again. It's too close to this episode, but definitely stay away. Move only what you need to.
The only thing that we didn't see last time, which is actually, I think, reasonable, I've certainly done it, is get the number for your local snake catcher and and put it in your mobile phone, because if you find a snake in your hands, you don't have to Google, or ask on your community Facebook group. Now is the time to ask. So
it is very stressful.
There have been scary pictures of snakes actually in houses getting rescued by the snake catchers. I think knowing how to get hold of your snake catchers should be in there along with your emergency plumber and emergency electrician, all the rest of it. I think knowing where your snake catcher, get hold of them is good. on speed dial.
Especially if you live in an area prone to snakes like we live in.
Live and work in. Yep. I think
very good.
That's all the
Excellent.
things, Dr. Moz. Ed, we've kept to time. I can't see a clock. How are we doing?
I think we're doing okay. I think that it's hard to say, obviously, because we're going to edit some stuff out. But I think we're going to be a smidge over 20 minutes, but hopefully under 25.
Yeah. Perfect. Well, thank you, Dr. Moz, for our first podcast of 2025.
Indeed.
The next one will be 2 weeks from now. We can share that we'll be looking at bone health in our next few podcasts. So the next one will be a deep dive into bone health, particularly what you guys can do to help protect your bones. But more on that next time. So thank
Fantastic.
you, Dr. Moz. As always,
thank
you were
you,
amazing.
Dr. Anne. And for anyone who's made it this far into the podcast, we appreciate you listening. Thank you so much for your ears. Please do make sure that you hit that like button and give it a 5-star rating on Apple Music, Apple Podcasts rather, Spotify and YouTube. Do give us a follow on the socials. Check out the Facebook and Instagram page and give us some love there. And I think the most valuable thing you can do if you're enjoying the podcast is share it with someone. I think if you have enjoyed listening to any of the episodes, send it to someone else that you think might enjoy it so that hopefully we can reach more ears and be more valuable to more people. Thank you very much for your time, Dr. Anne. Much appreciated.
No worries. See you next time.
See you next time.